Hi, everybody. Thank you so much for joining us this morning for what we think will be a really interesting and fascinating conversation with a world-renowned scholar and leader and researcher, Dr. El-Bassel. Thank you so much for being here. We really appreciate it. I'm Tammy Govea. I am the director of the Center for Innovation and Social Work and Health here at Boston University, and we are so honored that the Graken Center reached out to us to help co-sponsor this series of events and these series of conversations with Dr. El-Bassel. So really just appreciate all of you here and all of the folks who are online as well. We do have well over 100 folks who are registered around the world. Hopefully more people will be joining us as their day gets going. We're suspecting also that maybe the rain held some people up, slowed some people down. Maybe folks are still looking for parking, but really glad that all of you are here with us in this space, our small but mighty space here on in the School of Social Work and Comment Lounge, and also for those of you who are online. So I've been a social worker for the last 25 years, and I also have a background in public health. And I have spent the vast majority of my career in substance use prevention and treatment and advocacy. I served in the legislature for 4 years, and a lot of the things that we talked about up at the State House is the mental health crisis, the opioid crisis, and how to make sure that we are drawing on the research that scholars are doing here in New York, all around the world, to really address these issues, not only at the local level, but also at the national and the global level. And so that's why, from a personal perspective, I'm so excited for the conversation that we're going to have here this morning. Can you go to the next slide, Jess? So what are we doing this morning? So for about 20 minutes, we'll have an interview. We'll hear directly from Dr. El-Bassel to just get a sense of her perspective on social work leadership, substance use treatment research, as well as how we can advocate for the kinds of policies that we want to see to make sure that every person has access to the evidence-based treatment that everybody deserves, right? So that's what a big part of our conversation is going to be this morning, is making sure that those who are marginalized, who have been historically marginalized, that we're really putting them at the center when we're looking at research, interventions, dissemination, and full uptake and scale of a lot of the things that we know that work, but we're not always investing in from a global and macro and policy perspective. We will have a lightning highlights from BUSSW scholars and professors, Christina Lee. Christina, you want to say hello? And Ruth Paris, right here. And Jordana Muroff, right here. Luis Alvarez Hernandez, right here. And Peter Treitler at the end. And then we'll have a conversation where Dr. El-Bassel is sort of not quite a fishbowl, but there'll be a discussion about key questions that each of our BUSSW scholars has about how they can advance their thinking, how they can advance their work, how they can advance their research and their scholarship to really have a deeper impact. And then we'll open it up to audience questions. Jessica is managing our Zoom attendees. For those of you who are on Zoom, please drop your questions throughout the presentations in the Q&A, and Jessica will flag those for us. And Dr. Christina Lee will be moderating the conversation, both with our scholars and with Dr. El-Bassel, as well as with the audience questions. I just want to be clear that this is not an event that is where we're offering CEUs. For the other events that are related to Dr. El-Bassel's visit and conversations, there are CEUs for social workers for that, but I just wanted to be clear because I don't want anybody to be upset at the end of this asking for CEUs. This is not a CEU type of event. So with that, I think we'll turn it over to our interview with Dr. El-Bassel. No, nope, you can leave the microphone. So the microphone is just picking up for people who are on Zoom. And Jess, will you let us know if anybody is saying anything on the Zoom that they can't hear us? Okay, perfect. So we have a couple questions that we'd love just to kick us off and to get us kind of going and get us warmed up a little bit here. And I know that you have been spending some time here in Boston. I hope it's been a really good visit and that you've found some deep connections with folks here, including students, early scholars, seasoned scholars, and researchers as well. But the first question we'd love to ask is really about your research. And how do you translate your research findings into practical strategies, ones that really have meaning for social workers, for social justice advocacy, And do you have any examples of policy changes that have really come from your research? Because one of the things we're really focused on at the center is how do we take research and put it into action, right? And that's how social workers are generally oriented anyways, is making sure that we're putting research into action. So that's the first question that we'd love to open up with you around. And welcome again, and thank you for being here.
Thank you so much for the invitation and for the opportunity to be in School of Social Work. I'm really, really delighted. I feel at home, and thank you for all the welcoming. When I came here in my way, I said, wow, I didn't expect to be among so many social workers, and I'm so delighted. I thought I'm coming to present two presentation, the medical center, and not seeing many social workers. I'm so delighted. So I am also happy to say that from day one, when I was in high school, I always wanted to create evidence-based solution to social and mental health issues that the community face. And I thought also that in order to create evidence-based practices, I need to be a social worker who also get the skills and knowledge of research and knowledge of statistics and methodology and knowledge of community. And I always felt like if social workers become research scientists are the best thing for the world because they can solve the issues by looking closely at the communities and need of the communities. So that's really my idea from the early stages. And when I did my BA in social work, I combined social work practice, social work research with methodology, with statistics, because I always wanted to use the evidence-based approach to solve social issues. And I continue with my career, and I was lucky to come to Columbia University School of Social Work, who really believes, as your school believes, in evidence-based solutions to social problems. I was able to really achieve my goal by being a student there, and I stayed at Columbia. I did my postdoc at Columbia, and I became faculty, and I'm still there at Columbia. But I was also lucky to work with two faculty from Columbia who believed strongly in design and implementation of evidence-based practices and take them right away to the community. And that was really the most helpful thing for me. And I'm telling all faculty, junior faculty and students is really to connect with people who are interested in intervention science that would teach you from the early stages of it. So, and early stages, I worked on a study with women, which I'm very interested in women's issues. And I realized the stigma that women facing, women who use drugs, women who are infected by HIV. And I realized that there are not many evidence-based interventions for women that meet their needs. And I dedicated my really career on focusing on these issues, especially women who are impacted by substance abuse, women who are HIV, women who are impacted by the criminal justice system. And I made a decision that I want to focus my many years of designing these interventions. And I was lucky to learn how to get funding in early stages. I succeeded to get a lot of R01s to design intervention and prevention models, but I don't stop there. I really, in my designing and implementing the interventions, I always have the vision of how to take this intervention and implement them in real world settings. Yeah. Give you an example of one of the intervention that I began to work on it. My first study was a HIV prevention for women in jail at Rikers Island. And one of my mission is to go to the jail, work with women, deliver an HIV substance abuse intervention in jail, and then link them to care when they leave the jail. So it's part of the intervention. That was my first study, and I was able to design this intervention, implement it in jail, and linking 70% of the women in the study into care in the community and follow them into the community for 18 months. And through this implementation study, so I designed the effective and efficacy intervention. I also learned how to integrate women into the community and help them to link to care. But also I learned that we need to change policy in how to link women from jail to the community. And one study that it's really about efficacy as well implementation and changing really policies at Rikers Island. This study, one study was able to change policy in a sense in how to target the women's need when they leave the prison and link them to care. So, and we published a lot from the study, and our findings influence really the state level policy in linking women to care after they leave jail. And also what I did in this first study, I reinforced the idea you cannot look only on substance abuse and linking women into substance abuse. You also need to talk about HIV. You link also to link the issue of access to the social support and social network, and also talking about integrated approaches. And this work took me far by designing other interventions, implement them in alternative incarceration programs and on methadone treatment programs. And your question around where do you stop? You design the intervention become really efficacious, and then I don't stop there. So there is a whole methodology that we designed to take the intervention, implement them in real world, testing how it's working in real world, publishing about it, and also talking to policymakers in really providing solutions to how to integrate these issues into the
Yeah. What were some of the challenges that you faced in doing that work and bringing it from, research, demonstrating efficacy, and then getting it into the community? I mean, that takes a lot of relationship building and probably a lot of trust building and time. What were some of the challenges, and what advice would you give to folks who want to follow in that similar trajectory?
The first really issue is funding to implement the work into the community. It's really very hard. I would say the majority of our interventions have been identified by CDC as best practices. However, when you think about taking them from best practices to real world, there is no funding to implement them. And if there is funding, it's always really limited, and it's hard to do it in a larger scale funding. So I would say that's really the major issue. The other issue, it's related to be an example. We designed an intervention for men and women who use drugs, a couple-based intervention. And the intervention was found to be so efficacious and so much excitement about this intervention, because a large number of women wanted to be an intervention with their male partners. We spent 5 years, we designed the intervention. The outcomes reduce HIV risk behavior, reduce substance use, reduce IPV, and we package it to take it into the real world. We got funding. We got funding, and the funding was great, and we went to a number of STI clinics, a number of HIV clinics to take this couple-based intervention and disseminate it in real world. There was some excitement from the administrators. However, what happened, the health insurance would not pay for couple-based treatment. They want to individually do it. We couldn't do it. Secondly, the agencies, they said, if you bring a couple, it takes a lot of time to train the counselors. We don't have time to do that. So the implementation, it was very challenging. We had to struggle with really introducing it, implementing it, promoting it. But honestly, the really adoption was very low. So that's one example of how hard.
Yeah, and I see a lot of head nods, and I think there's a lot of similar experiences that folks are facing in the work that we're doing here. I think we have time maybe for 1 or 2 more questions. So we're going to switch, since we do have some students who are participating remotely and here in the audience. In your role as an educator, how do you prepare the next generation of social workers to tackle these multifaceted issues and to really think through these issues at the intersection of health and social work and social justice?
Let me also say that I direct 3 centers at Columbia School of Social Work. One center, it's called the Social Intervention Group, that was established by my mentor in 1999, and it's still functioning. My mentor is not there, but it's still functioning. And the students are really interested in applied work. They're in this classroom, but they want to learn through the faculty working on the research in the center about really how to conduct research, how to produce evidence-based solutions. And we have so many students who are really not only interested, but so engaged in learning from the faculty or doing the research and doing the work to be part of the training. And at Columbia School of Social, we have a number of centers that we provide intensive training for students on not only learning what's happening in the classroom, but to learn what's happening in real world. So because our center focuses on intervention science and community-based research, we're working with so many communities that it really allowed the students to work on research, but to be out in the field and apply the research in real world. So that's really a great opportunity for the students. The other piece is that it's really, we see our students are excited about is that the faculty who are working on research and designing interventions can bring it back to the classroom and teach the students. The other piece, I have a T32 program for pre-docs and at the school and postdocs, but that the students were really excited to learn through this program in real world how to do research at our centers.
One of the things that we do talk quite a bit about in the school and at the center and in the field of social work is something that you highlighted in your introductory remarks, which is that social workers are oftentimes working alone with other fields, and we're oftentimes the only social worker in the room. What advice do you have for those of us who have continued to do social work and engage in social work practice, as well as those who are entering the field, how to navigate some of those leadership challenges and pull all the pieces together from our skills and our values and the methodologies?
Yeah, let me say that I truly believe in multidisciplinary collaboration. I believe strongly that exposing our work through our publications and our interaction and talking about the profession and how wonderful profession we have, it's so critical. We don't advocate enough to promote our profession. So we teach the students how to talk about the profession, how to interact with other disciplines. And if you notice in my research centers and my work, I always emphasize the interdisciplinary approach, not because I believe that it's important to have multidisciplinary work, but I want the world to understand the other disciplines, to understand our profession and our work. But it takes a lot of work. But we talk to students about this. From early stages, we tell the students about the importance of advocating about the profession, talking about the uniqueness of our profession, talking about, I always say, if social workers becoming a research scientists are the best of the world because we know how to solve social issues, we know how to work with the community, we have the skills and knowledge, but we're not good enough to promote our profession and to promote the uniqueness of our profession. I'm involved in a multi-site study called the Healing Community Study. And the PIs come from non-social work. I'm the only PI in the study. And it's a huge, it's a $350 million study. It brings 300 scientists. I'm the only social worker among all the scientists. And I have to do a lot of work to show them that we know how to do science, we know how to promote our work. But I had a mission really to show social workers can be also very productive in producing science. And also, we are also doing work that other professions are not doing, the clinical work, the advocacy work, the policy work. And there is a room for really advocating more for our work and our profession.
And also the really community-based participatory research and really embedding the work and the person in their environment. I think that's another additional skill set that feels really critical and really unique to our field that we also talk quite a bit about.
For the Healing Community Study that is community-based research, it was for us, for social workers, it was natural. It was like, yeah, we're doing it all the time. We know how to do it. And I noticed for other professions who are involved in the Healing Community Study, we have, they have to learn how to do it. It was a piece of cake, as we say, for us to really say that's part of our profession, that's part of what we do, that's what we live in. So I'm proud of the profession that it's part of our culture and our education and our research and training.
That's great. Thank you. We have so many questions that we could cover, to be honest, but we're going to start to move to the next section of today's agenda, which is having conversations with folks who also are so dedicated to the field of social work, to their students and to research, and to putting people at the center of a lot of the work that we're doing. So first up, we'll have Dr. Ruth Paris, who's an associate professor. Ruth, you've really been recognized for your expertise in trauma and infant and early childhood mental health, including a particular focus on families struggling with substance and opioid use disorder. And you've had support from SAMHSA and other federal funders and private foundations. She's developed and evaluated multiple attachment-based interventions targeted at vulnerable families with young children, and has served as a subject matter expert for SAMHSA and HHS and Mathematica policy research regarding interventions for parents with SUDs and their young children. Would you like to come up here?
I'm fine to do this.
I have
Can I
it on
have your
here.
computer?
Yes, absolutely.
Just so I have an idea of what I'm,
Absolutely.
and I'm gonna, I don't know how to do this.
No worries.
I'm sort of like, I just start by saying I am impressed that you knew in high school that you
Yes.
wanted to be a social work researcher.
Yeah.
I kind of knew I wanted to be a social worker, but I did not put the research in until, interestingly, I worked in a hospital. And I felt like all of the MDs and PhDs were getting all the credit for all the work that we were doing.
Yes.
Right. And I felt like, well, why aren't there any social work researchers in this hospital? And it was a pretty big hospital. And that's what got me to go back
Oh, wow.
to get my PhD. So, okay. Hi, I'm Ruth Paris. Hi to everybody. I don't know where the camera is. Oh, there. So I'm going to talk quickly a little bit about what I have been doing. So I really appreciated what you shared, because I think you answered many of my questions already. But as I said, I came into the field by doing the work. So I went, got my MSW, and I practiced for a number of years. Started out as a NICU social worker. So that was it for me with babies and parents. So I sort of, and all of my work has been with children and families, both as in the field and then as a researcher. And and I saw that they were doing really interesting things in the field. My colleagues, very wise, right? Wise practitioners. And so my research agenda pretty quickly became partnering with people in the field to either establish the evidence base for what they were already doing, or collaboratively developing the evidence base for pushing the edge, right? In terms of, sorry, I keep going back and forth here in terms of talking. So I work with community organizations in terms of looking at the strengths and stressors of what's happening for parents and young children in particular, because I believe you have to intervene early if you're trying to change a life trajectory. And in the last 10, 15 years, I've been working a lot around parents who have an addiction issue, and we do know a lot about what happens for people with long-term addictions, and what happens both in terms of the lifestyle that people live, the lifestyle that people have come from, and also what happens in the brain, and all of those things impact parenting. And so in order to not repeat intergenerational trauma and intergenerational substance use, my work in collaboration with community colleagues focuses in trying to make a difference in the parenting practices in order to shift that. So we are aiming to improve the parenting capacities, the parental mental health, child development, and the interactions that happen. Full disclosure, I'm trained as a family therapist. So although a 2-year-old may not be talking to you, they are telling you a lot about what they think. So that's my population of focus, young children living in high adversity. I've also worked with immigrant families and other parental mental health challenges, but for today, we're focusing on parental addiction. Use a lot of different kinds of designs. I've done quasi-experimental, single group pre and post-test designs. That's a whole nother question that I didn't raise, but doing kind of real world research in the community and running clinical trials is a whole other interesting, right? I know that I didn't put that in, but that's really a good question. I have currently a longitudinal qualitative research study that's actually pretty interesting. I have done pragmatic randomized clinical trials, and that's the one that Miriam mentioned earlier, and I've done lots of program evaluation. My current projects, the one that I'll just focus on is working in collaboration with my community colleagues around the development, evaluation, testing of BRIGHT, which is it stands for Building well, I'm not going to tell you what it stands for. So all these acronyms, it's a dyadic therapeutic parenting intervention for young children who are living with parents in recovery from substance use disorder and opioid use disorder. April worked on that project and did an outstanding job. She worked on the RCT. And we're now, nicely enough, gotten funded. So HRSA funded that clinical trial. SAMHSA is now funding for the 4th time an implementation of the intervention. We've been in methadone programs, we've been in family residential programs, and now we're in a pediatric medical home that specifically works with, at our hospital, Boston Medical Center, that works with children who were exposed in utero to substances or are living with a parent who has an addiction. And we're going to be working there for 5 years implementing this intervention, which focuses on parenting. And just a little shout out to my colleagues within substance use treatment. There's wonderful things happening with substance use treatment. The vast majority of people between the ages of 18 and 60 within substance use treatment are parents. Not everybody, but definitely the majority. Very, very little happens around parenting in substance use treatment, right? It's just like another thing to add on. There are parenting groups sometimes, but generally we see in our work that if you help people with an addiction and support recovery, of course, that's going to lead to better parenting. But actually, if you help people with parenting, it also is going to help their recovery. So it happens in both directions. And so, sorry, I'm like a broken record because I do this all the time in substance use treatment. It's like pay attention to people's parenting, which is a pretty central role in someone's life if they're a parent. Okay. How am I doing on time? 1 minute?
Yeah, 1 more minute.
Okay.
Great.
So I've got a bunch of different, and also interested in training both here. I teach about these things, but I'm interested in thinking about workforce development in the state and in the country in terms of training people to work with young children and to break the cycles of trauma, addiction, et cetera. It's one of the projects. And in general, to your point of evidence-based practice and uptake, we put in some funding to WT Grant because they have an interest in research uptake. And we'd love to get funded to analyze and understand the absorptive capacity and increase use of evidence-based practice within Massachusetts children's behavioral health systems. So there's a whole field out there now, and we produce all of this evidence, but like who's using it and what gets people to use it, aside from the things that you mentioned about funding. But there's lots of other barriers to taking up our very good practices that we're developing. So how's that?
That's great. Thank
Okay.
you, Ruth. Excellent. Now we'll hear for a few minutes from Dr. Peter Treitler. Dr. Treitler is an assistant professor who aims to improve the well-being for people with substance use disorders and inform more effective solutions to the nation's critical substance use challenges. His research examines the implementation and outcomes of health services for people with substance use disorders and how federal, state, and payer policies shape their treatment and recovery experiences. Do you want to present from here? Do you want to present up here?
I'll stay here.
Okay, do you need my computer or are you good?
No.
Okay.
And that
perfect.
microphone's good enough, Tammy?
And that microphone's good enough, yes.
So
Yes.
first off, I want to say thank you so much for coming here. I learned so much at your talk yesterday, and it also helped me think a little bit more about my own work. And I really appreciate your focus on the structural and social determinants that impact addiction and a lot of the other social problems that intersect with addictions. And you know, I think your work really speaks to how important it is to address those factors, which is something that I think social work makes a really important contribution to, because that's really our domain is helping clients address all their psychosocial needs. And I also want to thank Bacon for this opportunity and for bringing us all together, because I, like you and like everyone else, I really value multidisciplinary work. And most of my research, I'm new to BU, but in the past I've worked with different teams and physicians and public health, and I appreciate also that you brought in the economic side with some of your interventions, because it's all connected, and that we all need to be working together and thinking about these issues from all different perspectives. But as far as my work, broadly I call myself an addictions health services researcher, and so I'm interested in real world studies using mostly existing data like healthcare claims and electronic health records to understand implementation of interventions in real world settings and what that means for patient outcomes. And then also using those same types of data sets to look at the policies, the policy environment, both, at every different level. So federal policies, like, we've seen so many changes lately. So some of my work is looking at expansion of telehealth, in Medicare, the new coverage of methadone. I mean, there's so much happening in this space, but and so using those data sets to study the policies to help guide policy decisions by other payers and states. Another big focus of mine is studying interventions that use multidisciplinary personnel. So a couple of things I'm working on look at peer navigation interventions. And those usually are not just peers. The peers are sort of the point person in a lot of these interventions, but they also include a prescriber, a nurse, a social worker, so sort of like a wraparound team. And my focus has been on people who are leaving jails and prisons. As everyone knows, that's a really high-risk period for overdose and another issue because of the care is often disconnected at that point. So I'm really interested in how we improve that, and then also just expanding treatment access. So, and this has been happening already, but further expanding access so people don't have to go to a specialty treatment clinic to enter, substance use disorder care, but that it's available when and where they want and need it. And that includes places like correctional facilities, hospitals, but also bringing treatment to the broader healthcare system, like community health centers, rather than just having it delivered in specialty settings. And then lastly, I'll say I'm interested in quality of care of addiction treatment because there's so much variation. And I think it's becoming an even more important question now because of how much the system has changed in recent years. With a lot of that has been brought on by COVID, right? There's a lot of treatment has moved to office-based settings, in some cases fully virtual, and I think it's really interesting to try to understand how effective treatment is in these different settings and where improvements could be made, and what do we want the system ultimately to look like. Okay, excellent. So I guess I don't really need to go too much into these. I thought I'd highlight a couple of the projects that I'm working on. And so some of this work I started while I was at Rutgers. I just graduated from a PhD program there in May, but fortunately I've been able to continue on some of these projects funded by NIDA that are looking at opioid overdoses in the national Medicare and Medicaid populations. But really the focus, a big focus of these studies is looking at policies, because using the national Medicaid data provides a really good opportunity for comparing different state approaches, policy approaches to addressing the opioid crisis. And then in Medicare, there's been so much innovation around payments and service availability, including new services or there's new billing codes for community health workers and peers, which is really all towards Medicare's effort to help coordinate care better in that population. So I guess I'll end there, and I'll save we're saving our questions for the end, but I'm excited to hear what you have to say about it.
Thank you. Yeah, great. Thank you. All right, and next we're going to hear from Dr. Jordana Muraf, who's Associate Professor and Chair of our clinical department here. And Jordana is passionate about developing empirically supported mental health interventions based in strong community collaborations to make them more easily disseminated, linguistically appropriate, and culturally relevant. She is particularly interested in health technology, innovations that help reduce health inequities and stigma, and improve access to mental health services for underserved populations. She has led federal and foundation-funded research studies in collaboration with community agencies. Are you staying there, or do you want to come up here?
I'm staying.
Okay, perfect. Of course.
That was great. That's great. Great. Hi, everyone. Thanks so much. I'm really honored to be invited both by Siswa and by Grapian today to ask and to be in your presence and learn so much from you. I really appreciate your your emphasis on social work, the role of social work in multidisciplinary teams, as well as we're really raising up what are real world problems and the integration around that. What matters most? You highlighted this yesterday at the talk in your question too, like, what matters most to the communities that we're working with, that, that's why we're doing this, right? Like, that's the whole point. So really, really appreciate that. Also excited, as you heard, I'm really excited about technology. So even though I'm somebody who's a Facebook refuser and everything like that, but in terms of thinking about it as a dissemination tool, so I'm excited about your talk later today as well. So one area of my research includes several specific projects on the development and examination of CASA-CHES relapse prevention for Latinx Spanish speakers. And this has been a collaboration between the USSW, Casa Esperanza, and the Center for Health Enhancement Systems at University of Wisconsin for 10 years or so. We've been really fortunate to have funding through SAMHSA that was focused on development and dissemination, and also RISE Foundation as well. And I've been incredibly fortunate to be on different teams, have people like Luz Lopez and Deb Chancellor and Linda Sprague Martinez, Dan Doe, others at SSW, and students and alum over time as well. Folks at Casa Esperanza like Macaudis Guzman and Juliana De Jesus, and Widener Alexandre, and also at the center, HS Center, Dave Gustafson as well. And all the clients that have been part of this, it can't happen without all those teams as well. So I've been really interested in terms of how technology may address, but not necessarily perpetuate, those structural and systemic factors and racism that you really highlighted yesterday and throughout your career of work as well. And also thinking about structural factors that create barriers to receiving relevant mental health and SUD services as well, right? So like, what are the factors that contribute to why SUDs are there? And then at the same time, then there's not access in terms of addressing mental health as well. So with this in mind, and to address those relevant gaps and inequities, we came up with the CASA-CHES app, as was mentioned, in terms of focusing on culturally and linguistically relevant behavioral health and recovery services. So what did this mean? It meant adapting and developing content for Latinx Spanish speakers with bicultural, bilingual staff, all kinds of adventures of implementation as well, examining the feasibility and acceptability of it, and testing it out in terms of various outcomes that hopefully were most meaningful to the client, both in terms of those who are completing residential treatment and then expanding out to those receiving integrated behavioral health services. So at first, our first development was on the Android. You can see it's like a kitchen sink app. Everything was kind of in there. And then more recently, based on the success and what we learned from the initial pilot, we had the opportunity to enhance it and launch a newer version that looks a little bit more in modern times. As well, and respond to some of the concerns and be more cross-platform as well, to be more available across iOS and Androids as well. Next slide. So the CASA-CHES app itself is based in self-determination theory, and the reason I really highlight that is because, of aspects around autonomy, relatedness, and competence. In addition to feasibility and acceptability, I'm really interested in engagement with tech-supported intervention. So I'm one of those people who really geeks out on like the back end stuff, like what's actually people using, because we can create all kinds of stuff, but what do really people care about? And what really came forward through the previous studies, which you can access if you went through the QR code, and the more recent one that I kind of stuck up there, is that the participants really want to connect with each other, through messaging, through discussion boards and so forth, even if they're some of them are there reading, not necessarily posting as well. But that's really, really key, and that they really value the interaction with other Latinx Spanish speakers, and also Latinx Spanish speaking case managers and providers as well. This is really, really important as well, using photos and other surveys and reminders as part of their autonomy as well. And also sharing their recovery stories, which has been a big piece as well. So our studies, multiple projects have kind of shown in terms of feasibility and acceptability, around 70 to 75% of clients use the app for 4 or more months, which at first I was super disappointed. I was like, that's it? After all that, it's 4 months, that's it. But actually, I found out that 4% of users who download an app continue using it after 15 days. That's it. So that made me feel better. Not that this was all about me, but just to kind of say you build the stuff, you hope it's relevant, and then, what are people kind of doing? The other thing is I was called the phone lady because I grant paid for the phones, which was great. But then, of course, we had more limited funding and we couldn't do that. And I wondered if it had to do with the phone. Our most recent, more study that we just finished show that 51% actually remained active on the app for 3 months when it's just the participant's phone. And think about, paying for a phone, interruptions in phone use and all that. And so people still kind of stayed really connected to that. So thinking about social support within the Latinx community as essential for coping with the stigmas around SUDs and different mental health disorders, and managing all the different social determinants of health that have been raised as well. It's also a space to really raise community strengths, address those health inequities, and also we used it over time. It's evolved in terms of the kind of information, so around client rights, information around COVID, of course, in terms of promoting vaccine equity, overdose prevention, and so forth as well. And so what really came up too, next slide, was the use of actual photos. So again, the technology allowed a camera, and people were talking about photos in terms of sharing motivation, but it also led to the integration of some projects around using photo voice as an example to better, for example, to better understand key factors that facilitate and impede recovery for Latinx Spanish speakers, and to inform treatment and policy decisions as well. So this is just kind of one example from one cohort that had taken photos on how different ecosystems have influenced their recovery with substance use over time, and they called it Nuestra Recuperación, our recovery, and really highlights hopes and challenges and power structures that can inform and change at institutional and agency levels as well. There's a number of other technologies I've been integrating with other mental health research, but I'll stop here in terms of generative AI and so forth. So I'd love to hear your thoughts about technology as well. And
Thank you so much.
I'm
Next.
sorry to interrupt. I just
Yeah.
wanted to ask if anyone wants a beverage, a bagel, or a parfait. I can bring it to you. Please let me know, because it's my pleasure. It'll make me
This
happy.
is exactly what Mitra does. Mitra's our program coordinator at the Center for Innovation. So
Would
always
anybody
wanting
like
to take care of
anything?
us.
So nice.
That's a nice commercial break. Thank you, Mitra. Thank you. Next, we have Dr. Alvarez Hernandez. He'll talk about his research focused on the well-being of Latinx, LGBTQ+, and immigrant communities, with a particular attention to the experiences of people living at the intersection of these identities. And his teaching and his research are informed by over 10 years of experience as a bilingual English and Spanish clinical social worker in mental health and healthcare settings, and by critical and feminist theories. Professor.
Thank you. Just like my colleagues, super excited to hear from you and share some questions with you. I spent a lot of my career in substance use treatment, particularly for people at risk of contracting HIV or living with HIV. So my research is in other areas that you also cover, like HIV and violence. I'm interested in documenting the social determinants of health affecting the LGBTQ, Latinx, and immigrant communities, but also as a social worker, I know that our communities are doing things themselves to address these social determinants of health. So I'm also interested in exploring how these solutions are being generated and implemented in the community. So of course, I look at things like community resistance and resilience, social factors affecting HIV and mental health outcomes, and more recently, COVID, also looking at things that impede or facilitate recovery, but in this case, for long COVID in communities. I'm also interested in how we use qualitative research methods in a way that is liberating for our communities, because I come from using a lot of Latina and Chicana feminisms perspectives. So I'm interested in how we are reflexive and how we address power dynamics as we do these research with our communities. And finally, how we can generate some systemic change to address these social determinants of health. I try to do a lot of community engaged research. You do qualitative data in English and Spanish. and then quantitative data for larger samples. A lot of my work as a social worker has been in the South. So I'm interested in seeing how the South looks in social determinants of health, but also specifically how certain communities are doing with qualitative research. Next slide, please. So I have a few projects going on. They all sort of overlap in what we would like to understand. The first one, like I said, was these factors that improve or hinder the recovery of COVID, particularly with Latinx communities at the US-Mexico border. I was previously in an institution down in that region. So we're trying to understand different areas of that community, including COVID recovery. The other thing I'm working on, it's on an open access book with testimonials from gay and trans men about their experiences with discrimination, mental health, and joy, also at the US-Mexico border. Also the experiences of LGBTQ Latinx people living in the Southern US with healthcare and mental health services. We have some quant and qualitative data that we're working on. Let's say clinicians need to do better for LGBTQ plus Latinx communities. And then the last one that I'm listing here is how stigma and social support impact adherence to care and viral suppression among LGBTQ plus Latinx individuals living with HIV at the US-Mexico border. We found a lot of different nuances in that area because people typically have families and known ones on one side of the border and the other. So they may have disclosed their HIV status to one side versus the other. And what does it mean to do interventions and have these relationships on both sides when people are trying to stay healthy with HIV? So a few of the things that I would like to do following this line of thinking is develop and implement an intervention that increases social support and decreases HIV stigma, specifically along these border regions communities. And the other one is developing and implementing a multi-level intervention to increase the inclusion of people who speak languages other than English in clinical trials. This is something that I've submitted a proposal recently with Dr. Linda Sprague-Martinez to also look at the systemic part on how we're including people in clinical trials. Based on this, I have some questions, but Christina first.
Thank you. Excellent. And now Dr. Christina Lee, Associate Professor. The goal of her research, which tailors interventions by addressing social and structural determinants that affect substance use among culturally diverse individuals, is to promote health equity in addictions treatment research. So that's what she's really focused on. And she serves as senior editor on several journals and teaches the MSW course on substance use and treatment, in which a specific focus is on the consequences and causes of substance use as a social justice issue. So one of the key parts of our theme and our purpose here today.
Great, thank you. I just again wanted to reiterate, just thanking first the Bacon for bringing Dr. DeSalle here, and the talks that we benefited from are just so inspiring. And also Bacon, excuse me, for the opportunity to bring together all of these great researchers. I mean, I've enjoyed so much hearing about what each of you do, and just how kind of thoughtful and multifaceted it is, but also more with a gentle frame, which you don't hear so much in the like studies get presented very differently. So this is really good question. Okay, so I'm just going to focus mainly on this one study. It's based on, so I really like what you said earlier about using evidence-based research to solve social problems. So I don't know if this has been a good thing or not, but my thinking was, if I can kind of document that things make a difference, then maybe policymakers are more likely to listen. So I kind of, this current implementation hybrid trial is based on prior clinical trials that I've done that have shown some positive effects. And so the intervention is to reduce stigma mitigation. It's based on culturally adapted motivational interviewing, but because of its emphasis on stigma, we are also including Black adults. So it has been a real learning curve for me to try to push, so in the, study that was done under controlled conditions into the real world. And to train those two community health workers who now, like, I see this as a big, I mean, I don't know what the NIH thinks, but when my community health workers want to help with the research, like, I don't know what our sample size is, not great, but I'm happy about that, So, but that has been an issue because it's not just the community health workers, but it's the staff. It's where the patients then go to get care outside the institution. That really affects whether or not intervention is going to be done. Like, this is what I'm learning. So these studies, anyhow, going back to the primary aim, obviously, we're just trying to train people, do this short intervention. It's been stripped down to its like skeleton. Just do 3 things, and then compare that to treatment as usual, which is wraparound care, which is a very high standard of comparison. They're already getting peer navigation. I mean, is this going to make a difference? We don't know. So, but those are my outcomes. Obviously, reduction in drug use, which I'm always like, if we could persuade funders to consider things like reduction, like increased use of condoms, and link that, like better housing, link that be, and then track substance use forward of that. But I think that's another conversation. But anyways, we are trying to also trying to increase their engagement in aftercare as an outcome. And also I threw in motivation sequence points. So those are some of the co-investigators at BNC and community health workers. So let me see, I don't think I have anything else to say from this. One thing is that the patients are enrolled in complex care management, which is not primary care. There are people who have multiple adverse social determinants. They're chronically and behaviorally, the chronic medical conditions are medically complex, but also behaviorally complex, which I didn't realize until then. I entered meant that many of the patients are in recovery. So you can imagine you screen people for substance use and you're happy that they're not using, right? But that's not, so that is the construct of this. Just wanted to add that the intervention that this is based on, I have an app developer who wants to do an NIH Small Business Award and I think that it should be targeted to women who are experiencing domestic violence because of like it makes it so much easier, to get help, and maybe even people who are perpetrated. I think it can be gender based, but anyways. So that's kind of where the status of where this work is. But if you go to the next one, I think what I wanted to highlight to you were 2 interesting patterns from the data. So the first thing is you see we screened 317 people and we only got 41 who are eligible, only 13%, which is shocking. And like the reasons include, okay, they're not Black or they're not Latino. Okay. But they're also saying that they're not drinking. 174 say they don't drink at all. So, I mean, I know that's probably the case in many times, but I have had other instances where the CWs have said that's not true. I know this person, she carries alcohol with her, and so that got me thinking about like, it's very understandable that people would want to disclose because there are consequences. Have criminal justice, histories or, women, like, that Latino women are group that have the highest likelihood of losing their children because of substance use, probably because they don't understand the system. And so they're really trying to understand that. And so that's the first thing. It's like self-report and how do you, and even if we give people assurances that we have this certificate of confidentiality, they have good reasons not to tell us anything. So that's where having a community health worker wanting to help us to recruit and block me. But the other interesting thing is once they get in, so we've been able to get 42 people, about half and half Latino, everybody enrolls. Like 100% say, okay, which is great. So that means that there's something about it that they like. I think it's the packaging of having community health workers deliver it, that they trust them. And then our retention is also good because 3 months, 79 to 100%, stay in 6 months, 91 to 92, and 12 months is we're at 100%, 83 to 100%. But that's of those who are scheduled to complete follow-up. So the lower included people. So that's the pattern. And I don't know, maybe I'm ahead of time, which would be great. But-
We're like right on time.
Right
So
on
yeah,
time,
we're doing,
okay.
we're doing well. Yeah.
Okay, so I just feel like it's a intervention that I do have heard anecdotally that I don't know if I have another slide. Oh yeah, can you go to the last slide? Okay. So this is why I think it's interesting. I interviewed clinical staff because I don't think you can ask people about experiences of structural stigma who experience the stigma, right? You can't say, so when's the last time you've had structural stigma happen? So you can only analyze it through the perspectives of people who witness the system, who understand the system. So what's interesting to me is that a community health worker in the first quote, who's Latina herself, she describes structural stigma, which is also defined as cultural norms, against disclosing substance use. So that got me thinking that community health worker feels this way. Is she going to want to do the intervention and talk about substance use when she's trying to promote a relationship, right? And this, the second quote is the example, I think, of self-stigma, where the community health worker is describing women who won't come out for help because they have stigma, not just, like in the communities, substance use is not encouraged on women, or they're denigrated. So that just got me thinking that I feel like these are the two things. And so then, maybe if I were to do a do-over, how do we here, like, do this multi-level thing? Because I think that's what we should have done, is to like talk about stigma at the provider, level and institutional level, not just at the individual. That's what might have made it work better. That's it.
Well, thank you so much for all of the quick highlights of what I know is a really deep and rich body of work for all of you. We are now going to move into the moderated discussion. We have, I think, 2 slides of questions that our panelists, our discussants, put forth. And so they're kind of lengthy, but they're because they have context. Right, context is really important for social workers. So I'm not sure exactly how you want to moderate this part, Christina. If you want each person to say a little bit more about theirs, I kind of group them together so that we sort of hit highlights, and then but there's 2 slides worth of questions. So hopefully we can get to those between now and 10:40, 10:45.
So each of the questions are from the presenters.
Yes.
So we should just go in order of presentation. We have the question maybe and the discussion.
Great.
That
So
helps.
can you go to the next slide, Jess?
And then if there are questions from.
And Christina, yours is the very last question, just doesn't have your name. So Ruth, yours is the 3rd question, the 3rd bullet.
But
What are effective strategies?
if I have a question outside these questions, can I
Yeah,
ask?
go.
Yes. And my question to you, the last question. I first let me say this is so impressive, so amazing work. Thank you for the great work. You started your presentation by talking about a hybrid model. Do you think we should go to hybrid model and forget about efficacy, effectiveness, and start combining in order to get faster into implementation research?
I do, but I think that there's so many, I don't know, like I do, that's my short answer.
Yes.
I guess in order to launch an effectiveness, like that's the 3rd stage in the NIH kind of developmental, like effectiveness is stage 3.
Yeah.
Okay? So you have to prove stage 2. And so that's where the hybrid comes in. So it combines efficacy in real life.
So you're proposing, which I fully agree with you, to shorten the time for producing evidence-based interventions is to combining the efficacy with effectiveness and implementation questions.
I agree with you. I think there's so many ideas with how to change the design. know, and like maybe we front load and front load. And it's just so frustrating to do all this work and then be told at the last minute, like, we can't do this because insurance won't cover. Like, why can't we know that before? Right?
Yeah.
So
And there
that kind of
is,
design.
my impression is with NIH, there is interest in shortening this period by combining efficacy and implementation and answering questions that will really lead to both the implementation and the efficacy at the same time. And there's so much funding now around this issue, the hybrid model that you presented.
The hybrid model that I used it's right now, I think it could use updating. It was developed a long time ago, but people aren't just now using it.
Mhm.
But I think it could use, and I think a lot of the work that you're doing is that.
And Ruth, I think your questions sort of fit in this bucket anyways, because we are talking about dissemination and uptake. Do you want to?
Sure. I mean, I think three of us at least, and I think all of us, Peter, I'm only saying not you because you're not doing as much this kind of on the ground intervention stuff, but if you are, is that we're working, and I think this is what's happening a lot in social research, and is that we're doing it, we're testing it, we're sort of doing it all together. And some of that is with NIH funding, and some of it was with other funders, right?
Mhm.
Because I think we're interested in the best ways of quickly getting things out there.
Right.
And so the model from whatever, when it was 2014 or before, which is and maybe even earlier, which can be 10 to 20 years,
Yes,
is just, we're social workers. We know that
17 years.
right, 17 years, right? So if you're going to go from all the way,
Yeah.
and then by the time you get that intervention, who's going to use it? So I think I look at my colleagues and I think, yes. So anyway, the question is, what are your strategies for quickly disseminating findings in ways that you might, maybe we do have some findings, Christina's findings, how much longer, what do you test before you get it out there?
My first response to your question is the hybrid approach. I'm reinforcing now when I start only focusing on hybrid approach, because efficacy, effectiveness, implementation in the same design, and answering very important questions that the answer for the question will help us to be faster ready to this for dissemination. The second part that I found and you all do it, is really very helpful to involve the community and having a community coalitions and community engagement integrated in the approach. So we're faster, you involve the community in the dissemination of the models and getting the feedback of the community faster, that will help you to disseminate the model faster. So those are the strategies they have been using, and the healing community study is the model, really having a coalition within each community to be part of the whole process of designing, implementing the intervention and ready to be disseminated. To give you an example, in New York, we have 16 counties. We created the coalition within each county, and the coalition makes decision about the intervention and delivery of the intervention. And we finished the first phase of the study, and because we have the coalition from the community, we sustained and we disseminated them. We got funding, and the coalition sustained in the communities. Because of the communities involved earlier, we use hybrid approach. It helped us to disseminate faster than waiting 5 years to finish the efficacy trial, 5 years to finish the effectiveness, and then go to implementation research. And then it takes 17 years at least. So that's really my new approach to doing intervention science.
And you think this is valued at NIH?
Yes, and an example is the healing community study, and I have been funded in a couple of studies using the hybrid approach.
Peter, I think your question would be next.
Sure, yeah. So I had a question about treatment retention for patients with opioid use disorder. So we've seen so many changes in access in the last couple of years, to where in some places it's pretty easy to access treatment, certain types of treatment anyway, not everywhere, and there's still plenty of gaps, but it's certainly a lot easier than it was 10, 20 years ago. But even with that, many people don't come into treatment, and then those who do, they typically drop out pretty early. So I think less than 40% or so of people are retained on medications for opioid use disorder for 6 months, and that's kind of seen as like a benchmark for duration of treatment to have a beneficial effect. And so I'm wondering, like, why do you think that the rates remain so low, and what can we do at the individual and structural levels to try to improve that?
Yeah, I'm engaged in a study linking people living prisons and jails into drug treatment programs. And as you know well, that many jails in New York and probably here too, and prisons, they don't offer any kind of MUD in the prison. And when people leave the prison, they have no access to any treatment. What we decided to do is to create what you mentioned, navigation to services, to navigate people immediately to services and link them to treatment, but with continuity of linkage. This navigator will stay really connected in long term with the patients. And based on our it's a pilot study, we succeeded to maintain people for a long time, and making people very comfortable to disclose their issues and also navigate them to different services, because we have so dismantled services. People cannot go to different services at once. There is no integrated models. So I believe strongly in navigation to services. Really is a huge help to maintain people in services and help them to go to different services, because that's when you lose them. The services are so dismantled. Mental health, substance use, HIV, they're not in one place. Addiction, not in one place. And we cannot put them in addiction services and not getting them on the services. What I found, especially with people affected by the criminal justice system, is a true navigation to services and help them to be able to get to services. That's really what I see that's so critical. And I heard you talking about navigation, that you're using the services, correct? In one of your studies, that you think it will be helpful.
Yeah. One of the studies I'm involved in New Jersey is it's similar to what you described in New York, where they use navigators who establish a relationship with the people before they leave prison, and then continue with them for a year in the community. But even in that program, there's been quite a lot of attrition over time. People typically only stay engaged with those services for 2 or 3 months. And so I was also, just to follow up, because you talked a little bit, I was struck yesterday in your presentation about how, like, you were asking people who had experienced interpersonal violence, like what's causing them to use, and that was a big part of it. It was like the trauma related to that. And so I was thinking, like, our substance use programs really addressing what is most important to people. And then the social determinants, I think, is another thing that keeps people out. If you can't get them linked to a good job, not just something in the a service job that's not going to help them advance economically, is there really a chance of them staying long term?
It's really so sad to see how dismantled and non-integrated services exist. It's really hard really for people to get services when they have to go to so many places. And I described yesterday, even in my presentation, about women getting to domestic violence shelters. They don't accept them, and you have to look for other places. The HIV care doesn't deal with substance use. The substance abuse system doesn't deal with HIV. And that's really a system change that we need more than anything else. That's where I see temporary solution is the navigation to services, and active navigation to services is so helpful, because it's going to take a while to integrate services within the addiction or HIV or mental health. So the clients cannot really manage to go to so many places to get the services. And that's one of really the system barriers that we're facing in really helping people to get the services and sustain the service.
Yeah, and then we'll go to Jordana's
I
question.
just wanted to piggyback off what Peter was saying and my experience with understanding the navigation services and how they're looked at. And I think there's more of a history from what I know around navigation as it relates to sort of ED visits. And within Massachusetts, there's been a lot of effort towards improving community tenure with ED visits because there's many frequent users that will be back, and many of these are, have co-occurring disorders. And so there was a similar study done, and it had similar results, which were it didn't change the touch point. It having the ED navigator didn't necessarily impact return on investment. And it's interesting because if we measure it by that, right, it may not necessarily show us what we're looking for, because it may include an increase on investment in order to really see the impact that we want to see. And so I think that's one of the things is how do we shift the focus so that it's not necessarily that there was a higher community tenure with a lower cost, but understanding that it'll cost us more to see the difference that we're looking to see. And that's something we see a lot when we talk about the value of social work in health. So how do we change that sort of conversation? Because I think as we talk about what we need, we need more. We need more investment, more services, more unique thinking about how to sort of be more personalized in how we treat substance use disorders.
Yeah, I think it's a change of policies and systems, and it takes a longer time to change system and policies. And we have been, like you brought up the issue of the emergency department. There are models really working so well in the emergency department where you link people to care and stay with the care. And there is sustainability of the navigation. It's working. There are models that it's working. But also there need to change systems, and that's where we're lacking. We're screaming, we're yelling, we're talking with the, many people in power, and I really see that the change is very, very slow, and unfortunately.
Yeah, and I think the length it's taking for integration care is the most costly, and that's been probably the hardest piece with that.
And honestly, if you look at the addiction, HIV, integration of services is not happening. It's not happening. We've been screaming and yelling and writing about this and trying to advocate for change, and it's taking
Well,
too long.
I'll just say one more thing. Social workers have been integrating services from the beginning of our history. We've always sort of looked at what the community needs and adapted to that. And so I think it's a great discussion for us here today.
Now we're going to switch gears a tiny bit from the macro and the systems and the policy implications of our work and the needs for these big changes, as has been pointed out. Jordana, you want to switch to a tech-based kind of question?
Sure, thanks. And I know you'll be speaking a bit about tech coming up. So, but I think actually technology kind of sits at the individual, interpersonal, and societal level, right? Like in terms of that. So I guess from the standpoint of thinking about what are potential opportunities, but also cautionary considerations around the use of technology, so that we're not, either offering something that is kind of not as helpful, or making ourselves feel better because we're giving something but it's not really working, or we're using technology in such a way that might be perpetuating the inequities that already exist, or creating the haves and the have-nots kind of within that as well. So just kind of curious about kind of thinking about what are ways that you might recommend that technology actually might be most helpful or reduce the likelihood of what perpetuate harm.
Yeah, we found in our work that technology is cost effective and it's easy to use, the opposite of what many think that people of color and women and vulnerable population can use technology. The opposite of what they think. So we have tested different models of using technology for screening and linkage to care for women who are in an abusive relationship. And it worked so well. And when we introduced the concept into community supervision programs or prison and jails, the response from the systems is like, no, it is not going to work. No, it's not going to be used. And after 4 years of trying and testing the model, now it's really used in the systems. So I think the attitude, the beliefs, the really lead to denial of how these approaches can work. Based on my experience, we design 3, 4 brief interventions and test them in different settings. And not only the participants like them, the providers also like them. And it takes a while for the system to accept them, but it happened. Probably it happened to you in the same experience that you have. You mentioned in your presentation AI, and I was wondering how do you think about using AI in interventions research?
Yeah, great question. So I'm using it less from substance use and other areas of mental health, and so more from the standpoint of machine learning and assessment development as
Okay.
well as
Okay.
kind of where it's kind of been, but being careful not to. There's the balance between um, utilizing data that already exists, which could be biased, and how do we generate data on a large scale that is more representative at the same time as well. So so for this particular part, it's on automated assessment of home environments related to safety and clutter as well. And so it's more on my mental health other aspects.
So not an intervention, but you're talking about assessment.
So for that part is for assessment. Yeah, but I'm working with another group of folks in terms of also thinking about it from the standpoint of how do you generate intervention, even app-based intervention in terms of kind of the if you have an app and it's kind of checking in and what your responses are and how does that fit to kind of have a
Yes.
response back.
Yes.
And so they're kind of working through that as well in terms of figuring out how to have that kind of dialogue, so to speak.
Right.
Because I mean, to me, and from what we've seen, like the human piece is still very, very important, but the AI can potentially emulate some of that for scalability. Because if you always need a human, that's consumable, if you will, right? Because it
Exactly.
requires that level of input. So that's another way that.
Yeah, and I'm seeing the more really research is done around using it as an intervention, as you described. It's very innovative.
Louise, shall we turn to your questions? I think they're on a different slide, Jess. The top one.
So as someone who has successfully designed and tested many interventions, can you share some of your critical lessons learned in intervention development and implementation to address harm in our communities, particularly in community-informed or community-engaged interventions?
Yeah.
Well, we could probably be here all day with this
Yeah,
question, but-
yeah. You know, you're taking me 20 years ago to an example that I want to share with you. And as I mentioned, I am really very committed to designing interventions and using the community to give input and be part of the whole process, from thinking about the idea to writing the grants to implementing it. I use the community in all the stages to give input, to review things, to get their input integrated in every stage. And then when I get the findings, to get back and help the community to help in explaining the findings with me, and then in publication. So that's my commitment. It's part of the science that I do. I believe in it. We do it in all the studies. But in early stages of my career, and one of my studies was very excited to see that the female condom was introduced. And I felt like the female condom is an amazing tool for women to use it when they don't want the cooperation of the partner and they can stay safe. So I did a focus group until we start an intervention, and I introduced the female condom at that time. And one of the women who were in an abusive relationship went home and used it, and she was abused more and maybe beaten. And although we talked about how to prepare them in the intervention, and her experience made me feel like we have to be very, very, very careful in how we introduce core components of the intervention. And this lesson stayed with me from day one, although I felt like we explained to how to use it, when to use it, how to talk to the partner, but it was really a risky situation for people. So I in any intervention that I do, I think about the implications of every core component of it. I get feedback, I pilot the intervention, and I get the voices of the community before I intervene to make sure that we're not getting into making the negative impact on.
Christine, I think your question is on the next slide. And then we'll open it up to audience questions. Just there we go. Yeah, the last one. Yeah, perfect.
Yeah, so I was just wondering, I know that you talked about your structural interventions yesterday. So I was wondering, is it possible to do something like that together, or maybe you have? And what would that look like?
Yeah, yes, I love to collaborate with you guys. It's amazing, amazing group. It's amazing. So I'll give you an example of a structural intervention that we're embarking on is to reduce stigma. Stigma, as we all talked about, against people who use drugs is a huge one. And we, in the healing community study, we piloted a stigma reduction intervention using communication campaigns. And using communication campaigns and going to the community with the voices of the community and the providers talking about stigma reduction, and it through all social media aspects and billboards and everywhere in the counties to talk about these issues. And we're seeing a great outcome in reduction of stigma about people who use drugs or people on methadone or people on loop, or so we're seeing reduction by using this really approach. But costly, it costs a lot of money, it takes time, but I think that's really an approach that I want to take to the next level. If I'm talking about that's reducing stigma around addiction, we can do it around other problems like HIV or other health and mental health issues. I think that's one way to reduce stigma. The other piece, I talked about it in my presentation yesterday, is working with women who engage in sex work and employment. How we can go to employment places and work with them closely to reduce stigma toward women who use drugs or toward women who engage in sex work and they want to get engaged in employment.
Ruth, did you have something?
Well, I'm just wondering, I'm curious what the billboard said. What was it? What's the
like-
content of some of the stigma reducing?
No, a doctor's talking about how methadone is helpful, and physicians from the community. That's one example in the billboard. Or about naloxone.
Basically, the work around smoking is,
You can
of course, our
smoking,
biggest,
and we can
model.
do it for HIV,
Yes, that's right.
smoking.
Yes.
Yeah, I was just thinking, it speaks to what you were saying before, because if you're going to launch a study like that, it's almost like you need to have government officials at the table to talk about doing these ads at the same time that you launch an individual and train providers.
Yes.
Right, and then you have to create measurement of the structural stigma associated. I guess that's a big.
That's
thing.
what we did.
That's,
In
oh,
fact,
okay.
that's exactly what I did. And I didn't present this, but luckily you have to have the governmental officials. And tell you honestly, what happened in the healing community study is so powerful. Our study has a design where you deliver the intervention for wave 1 for a year and a half. And when we're done, is wait-listed control trial. You go to the next wave 2, other counties. So when we left the wave 1 counties, we finished the intervention, we finished the stigma reduction and other things. I was driving in 2 counties 6 months after we finished the study. I see a billboard with our work that the government put there, learn from our experience. That's the dissemination. That's implementation. I did take photos. Send it tonight.
That's great.
Wow.
So I know we have one question on Zoom. So Jess, do you want to ask that one question and then we'll go to folks in the space here?
Yes, so we have a question. They were hoping you could speak more to any challenges you might have experienced in implementing a hybrid approach to interventions in terms of technology and access technology. If you have any advice on.
I have, honestly, I haven't used hybrid model with technology. I haven't used this model. But I think the most important thing with hybrid model is what we are talking about is from the early stages, either use technology or you use in person or any approach that you use, you have to involve the community from the early stages of the research. The other piece is you have to collect so much data in the hybrid model to inform the hybrid model, the next phase from efficacy, effectiveness, and implementation. So you have to collect data on ongoing basis, and you have to have enough team, enough staff, and enough infrastructure to be able to do this work.
Could you just, there are probably folks who don't necessarily know what the hybrid model really is because we have students or early career folks. So could you just explain a little bit what we are talking about? And I heard the words efficacy and effectiveness and implementation, but that might help round out this part of the conversation.
The efficacy trial is we answer the question whether the intervention works in a controlled environment, very controlled environment. And you move to efficacy trial, you ask the same question, whether the intervention works in real world, because you use clinicians to implement the research. And then when you move to implementation is you take the intervention and implement it in the community and ask question about what factors may impede or promote the implementation of the research that you do. So in the hybrid model, you combine all these three stages together.
Which is why you need more resources
You
and
need
more
more resources.
forethought and the buy-in of funders, et cetera.
Exactly.
Yes, exactly. Great. Any questions among the audience here in the room? Well, I have a question.
I have some questions too, but go ahead.
Okay,
You'll
so
have questions.
I did my doctoral research on the non-arrest policies of opioid use and addiction here in the state of Massachusetts. And part of what informed my research was a comparative analysis with other countries, including Portugal, and the approach that they've taken. And in the design of my research methodology, which I'm similar to you, like I never really left BU. I did my master's in social work and master's in public health here, and then my doctorate in public health, and then came back now as the director of the center. So we have that in common. But just curious, one of the things that as I was doing the research and looking at the comparison, in other countries, they have single payer healthcare. They have one entry, they have one door, which seems to drive some of the thinking around how access is just a little bit easier in other contexts than it is here in our very convoluted, very privatized. And that also leads to a second question I have, which is, how are you and any of you thinking about the move towards privatization and how that's going to impact emerging trends and things that we might want to be thinking about? Because I think we're going to be living with, from a structural systemic level, the impacts of privatization, the move towards privatization, and the basically not democratizing, but going in the opposite direction when it comes to access points. So kind of
Maybe
combining
other
both
things,
those questions.
I mean, I'll start. I think it's a great question. It's something I've been thinking about a lot because when I talked earlier about how I'm interested in looking at how the system of care is changing and my focus is on addiction, but these are bigger issues impacting the whole health system, and the move towards privatization and consolidation, which could potentially further drive up costs and reduce competition in certain areas. And then also I think the fact that there's a profit motive underlying a lot of these business decisions, right? And I'm not sure that doesn't always align with quality of care and what's best for the patient. So I think it's a major concern, and there's going to need to be more regulation around that. But I'm not sure, based on what's happening politically, if that's.
Yeah, and I think you're raising a good question about quality of care. That's the issue that I would worry about.
I would also just add, and imagine my colleagues agree with me, is that as researchers, you have to do millions of different things, but one of the things that you need to use the evidence that we develop in a quick turnaround way at a policy level and at a political level, right? So, I mean, obviously the people I know in other countries, this is such a different systems, and even actually some of the European countries that have voted in more conservative governments, they would never mess with their healthcare system. So it's such a given that there's universal care, from better or worse, depending on the country, that it's just a given that's something that's like a basic right. And that even though there are some countries that are moving in a more conservative political direction, we just don't have that. We don't have that sense that everybody deserves to get healthcare. To me, that feels like if we could move the needle on that, that would be like, just
Open it up.
that would
Yeah.
be huge,
Yeah.
that we could take on
Yeah.
coordination of care and
Yeah.
all of those types of things. But it's kind of amazing to me that we still don't have that. Having to explain it to people, obviously, from other countries,
Oh,
where
that's,
it's just sort of like,
There was a wonderful talk that our Equity and Inclusion Committee hosted last night, Just Sustainability. And one of the things that the speaker focused on is just our public spaces, transportation, even access to apartment buildings, that there's now 2 different doors. So the folks who have their private cars, they can just go up to like a quick elevator, and then anybody who's coming in off the street has to go in through a different door. So just the mindset that's kind of contributing to what we're seeing on access points and stigma, and the point you just, It was a really fascinating talk. It was so good. I encourage everybody to take a peek at it. Christina, did you want to put in on something or change the direction?
No, I actually just came back. I was just thinking, I think in terms of moving the needle, it's as social workers, like, the privilege is to understand that that's a pathway, but I think in other disciplines, like the barriers, like around findings, it's not really a barrier, but there's a lot of, questions. Like, this is really important to screen for trauma, racial trauma. Like, does that really affect substance use outcomes, those kind of things? And I think they're the change practice by using what we were finding. I think an additional barrier is professionals. Not either professional or maybe it's discipline specific, but it's academic.
I have a different question. Can I ask?
Oh, please, go for it.
I wonder about how you do your work and what kind of infrastructure you have at the school to be able to do all this intervention science work, because you need a lot of resources and you need a lot of infrastructure. I'm wondering, how do you manage? The center, is it the center that provides the resources, or?
The center's been, flexible and helpful with giving support. There's specifics around running a trial that require things that we're kind of working on making more clear, get help with it. So, not with the center, but more
The unit schools,
university
yeah.
based. So it requires a lot, like the multiple IRBs,
Yeah.
everything. Lots of bad things can happen.
I'll be transparent by the seat of our pants. I think people can say,
that. Yeah, that's
but
right.
but we use our lessons learned
Yeah.
to advocate for better. Look, BU is a fairly sizable
Yeah.
institution. There's possibilities here, and over the time that I've been here, we've gotten better and better
Mhm.
support, enabling us to do the kind of work that, I don't know that, Christina, if 15 years ago, if you would have been able to do that work through us here. And so things have changed,
Yeah.
and we've built better supports and infrastructure. So, but sometimes it's just a lot of very creative people who are sitting to my left who manage to do things and work very hard and work with different systems. And we have other, I mean, Christina's work has been in the healthcare systems and at Boston Medical Center. I've done work at Boston Medical Center. Jordana has done work there and in other communities that, so we kind of pull it together. If we had an amazing infrastructure, like I imagine you have at Columbia, I think, what could we do?
Hi, everybody. I just wanted to say that along these lines, I think, so I'm Miriam Kamarani, the medical director of the Breakthrough Center for Addiction. I feel like we could be stronger together, that albeit it is a lot of addiction medicine infrastructure, medicine at BMC, long track record of doing developing and studying clinical intervention. But we really have lacked appropriate input from a social perspective and social science perspective. I've been increasingly interested in figuring out how we can bridge that gap, because I think that there is a lot of knowledge and infrastructure there that can be very helpful, and an absolutely necessary, critical perspective from the School of Social Work. But often we don't meet and work together on things. And I think there's some examples of very successful work that's gone on where there is more of a collaboration. But I think we'd all be better off to find more ways to do that. I would like to work on spending the dialogue and opportunities with.
We agree. We're looking
Yeah.
forward to more conversations, Mary, for sure.
Jordan, did you want to add something
I just-
before we start to wrap?
Yeah, just real quickly, I think also that there's been more dialogue at the university level as Big BU around community engaged work and what that really means and how to create supports around that. And then, from the standpoint of facilitating that work, everything from IRBs to, to also thinking about tenure and other kinds of things in terms of what people need to do during a certain amount of time. So I think that that's, it's been great to see that there is more conversation at beyond faculty and relationships in the community and deans and provosts and so forth as well, because I think that that's crucial, right, in terms of institutional change and structural change, and see that recognition, and also what does it take to actually do that work in a real way, and hopefully retain people to be doing that work over time as well.
And I would say there's a lot that we can bring to Big BU around that because of our skill set, like just to kind of put a finer point on it. We have, Big BU has a wonderful strategic plan, and it does talk about equity. It talks about, really pushing on some of these things that Jordana just described. And there, I think, are tremendous opportunities for us to, in the social work space, to bring that skill set to, the folks here, but also higher ed in other areas as well. Any other last question? Because we have just a few more minutes. Luz, you get the last question, and then I'll wrap us up so we can end pretty much on time. So Luz?
So I just want to say thank you for this opportunity to hear such rich perspective and research and practice. And I feel very proud because as social work leaders, you are opening doors in incredible places of need. And one area that is happening now is the incoming displaced communities, immigrant communities that are arriving, and we are adapting some of these studies and interventions. I think there is a need for the integrated services, but also culturally adapted services. Latinx and all the other immigrants from many countries that are coming. And I work in these global settings here in US and abroad, and I think it's a moment of adaptation of these to serve those needs. And I think all of you are doing that in some way. And I feel like, how can we replicate this in those communities?
Absolutely.
Thank you for that. I'm glad you brought that into this space because we didn't get into talking
No.
specifically about also your global experience as well. We touched on it in various ways, but I also realized that I didn't give you a proper introduction because I got so excited to sit down and start talking to you. So I just sat down and we dove right in, but I think we covered a lot of what you're bringing to this work, what you have brought to this work, the ways that you're leading. And, you know, I'm really excited about the conversation that we started here, the things that we brought to the fore. I think these are things that we grapple with in social work leadership all the time, whether it's specifically around SUD or mental health, HIV, stigma, LGBTQ, health and well-being, you know, just making sure that people have access to the resources and the conditions to really thrive and to support their well-being. So I just thank you all for being here. We have up here on our screen for those who are in the room, please scan and give us your feedback on this event. If you're on the Zoom, you should also be able to just pull out your phone and scan the QR code on the left. We'd love to hear what you thought of this. We'd also love to hear, you know, what other kinds of conversations would you like us to take up? This might be a new model for us, bringing together our VU scholars with an external scholar and expert. And if you want to learn more about the center and sign up for our newsletter, you can scan the QR code on the right. And I'm going to turn it over to Mitra because she looks like she wants to say something about food. I'm a social worker, you know, and thank you, everybody.
Thank you very much. Well, here, first round of applause for everyone. Thank you so much. First of all, I'm just standing here, I just want to stand, but I want to take a photo of you all first. I need a photo.
Oh, let's get
I'm
rid
my
of like
father's
the
daughter,
junk.
so gotta do it.
Is your father a photographer?
I mean, he's been taking photos and videos of family our whole life. That's
And then
all
if
on
we could also
video.
get a photo with the Graken folks who are here as
Yeah,
well, since this is a
absolutely.
joint venture.
1, 2, 3. Beautiful.
Excellent. Miriam, you want to invite up your team?
Awesome.
I can stand.
Why don't we just have
Oh, you guys stand behind?
stand behind you.
Awesome.
The gorgeous lighting that's going in.